Welcome to your deep dive. So today we are unpacking the, frankly, staggering complexities of endometriosis and adenomyosis.
Right.
And our mission here is to relentlessly break down every single mechanism, every symptom, and the treatments from the data. Let's jump right in.
Sounds good. And, we are entering a diagnostic landscape that is famously murky.
Yeah.
You really have to start by dividing this beast into two main categories to even begin to understand it.
Okay, so what are the two?
So you have endometriosis externa, which is what you typically just call endometriosis.
Oh.
That's where functioning endometrium, so the glands and the stroma, sets up camp outside the uterine mucosa.
That's right.
Exactly. And then you have endometriosis interna, which is better known as adenomyosis. And that's where that exact same tissue is trapped inside the myometrium itself.
Inside the muscle wall.
Right.
And what immediately jumps out to me in the data is this incredible paradox.
Mm-hmm.
You are looking at what the text calls a disease of contrast.
Yes, that's the perfect term for it.
Because technically, medically speaking, you are dealing with a benign condition. I mean, this is not cancer.
No, it's not. Malignant transformation is exceedingly rare.
Right. But it absolutely does not behave like a standard benign growth at all.
Not even close.
You have a tissue that is locally invasive, it disseminates widely, it's incredibly aggressive, and it just relentlessly progresses.
It is a phenomenal biological contradiction, really. I mean, you have perfectly normal cells, but they are in an entirely abnormal environment.
Yeah.
And they start acting with the ruthless efficiency of a malignancy. They invade surrounding architecture. They actually metastasize to remote parts of your body.
Which is wild.
It is. But unlike a tumor that mutates to grow autonomously, on its own, this tissue remains completely tethered to the body's natural rhythms.
So it's still following instructions.
Exactly. Its entire existence is dictated by cyclic hormones. So the natural ebb and flow of the menstrual cycle stimulates it, while continuous hormones suppress it.
I really want to pause on that because if you think about it, it's just wild.
Oh, absolutely.
If it is entirely benign, why does it spread like wildfire? I mean, if you take seeds from a highly curated domestic garden and you just toss them into a wild forest, well, they shouldn't survive.
Right. They should just die off.
But here, they suddenly become an invasive species. They completely hijack the local ecosystem.
That analogy is totally spot on. These rogue seeds don't just survive, they terraform their new environment.
Yeah.
And when you look at the prevalence, you realize just how successful they really are. You're looking at a 10 to 15% prevalence in the general population.
Which is already high.
It is. But among infertile women, that number skyrockets to a staggering 30 to 45%.
Wow. Almost half. And those numbers are climbing, right?
Yeah, they are.
Because when you dig into the epidemiological data, you see both an apparent increase and a real increase.
Right. Let's break that down.
So the apparent increase is obvious. You have better high-definition diagnostic laparoscopy now and heightened clinical suspicion. You look for it more, you find it more.
Exactly. Better cameras mean more diagnoses.
But the real increase is fascinating because it's tied directly to modern human behavior.
Precisely. You have to consider the evolutionary context here. Historically, women spent vast portions of their reproductive years either pregnant or lactating.
Which naturally suppresses the menstrual cycle.
Exactly, it suppresses it. But today, you see delayed childbearing, lower parity, smaller family norms.
Right, people are having fewer kids later in life.
Yeah. And this means a modern woman experiences hundreds more unbroken cycles of estrogen and menstruation in her lifetime.
Which feeds the disease.
Yes. You are giving these rogue seeds endless opportunities to take root and flourish.
So knowing that these tissues are riding this wave of continuous modern menstrual cycles, where exactly are these rogue seeds landing?
Well, if you map the ectopic tissue, you start to see a very specific, almost gravitational pattern.
Okay.
The data divides these sites into abdominal, extra-abdominal, and remote locations.
So starting in the abdomen, where are we looking?
Inside the abdomen, the pelvic peritoneum and the ovaries are the primary targets. But the pouch of Douglas and the uterosacral ligaments are arguably the most critical and frequently involved sites.
Right.
You also see it on the rectovaginal septum, the sigmoid colon, the appendix, and even the ureters.
And the pouch of Douglas being a primary target makes perfect mechanical sense to me.
How so?
Well, if you just look at human anatomy and gravity, right, the rectuderant pouch, the pouch of Douglas, is the most dependent part of the pelvic cavity when you're standing or sitting upright.
It's the absolute lowest point.
Exactly. Any fluid, any cellular debris just floating in the pelvis is naturally going to pool right there.
Gravity is definitely the primary transport mechanism inside the pelvis, but when you move to extra-abdominal sites, gravity just doesn't explain it.
Right, because how did it get out?
Exactly. You start seeing endometrial tissue thriving in surgical scars. So hysterotomy, cesarean section, episiotomy scars. Yeah, you see it colonizing the umbilicus, the vagina, and the cervix.
And then it gets truly bizarre when you look at the remote sites. I mean, you're finding uterine tissue in the lungs.
Yes, the lungs.
In the pleural cavity.
Yeah.
In the skeletal muscles of the arms and the legs. Even in the nasal mucosa.
That's one of the most shocking parts of the text.
You can literally have a patient with cyclic epistaxis nosebleeds that are timed perfectly with her menstrual cycle because she has functioning endometrium inside her nose.
It is completely mind-bending.
It really is.
And it forces you to ask how this tissue travels so far. But before we unravel the theories of pathogenesis to explain that travel, you really have to look at the environment that's waiting for them.
The soil, so to speak.
Right. The risk factors create a very specific biological profile: low parity, delayed childbearing, genital outflow tract obstruction, a family history of the disease, and exposure to environmental toxins like dioxins.
Okay.
But the most vital risk factor is the internal microenvironment, specifically the peritoneal fluid.
Because the biochemical profile of the peritoneal fluid in these patients is absolutely hostile.
It's completely altered.
When you analyze the data on the cytokine and growth factor changes, it's like looking at a war zone.
It really is.
You have these massive upregulations of interleukin-1, interleukin-6, interleukin-8, TGF-beta, and VEGF. Meanwhile, interleukin-13 is actively decreased.
And you really cannot understate the significance of that specific upregulation of VEGF.
Vascular endothelial growth factor.
Yes. So when these rogue endometrial cells first land on the pelvic peritoneum, they are completely cut off from the uterine blood supply.
Right, they have no lifelines.
Technically, they should just die of hypoxia, but instead they pump out VEGF. This signal protein literally forces the surrounding healthy peritoneal tissue to construct new blood vessels directly into the ectopic lesion.
Wow. So it hijacks the local infrastructure.
Exactly. The lesion builds its own dedicated life support system.
They're essentially running localized angiogenesis to feed themselves.
Yes.
And while they were building that infrastructure, those elevated interleukins, the IL-1, IL-6, IL-8, are dumping massive inflammatory alarms into the fluid.
Constantly.
So you're turning what should be a calm, neutral space for an oocyte and sperm to interact into a highly toxic inflammatory soup.
Which perfectly explains the profound infertility rates associated with the disease.
Yeah, that makes total sense.
But you still have to answer the fundamental question. How do the cells get there in the first place? And how do they reach the lungs or the arms?
Right. Which leads us into the fiercely debated theories of pathogenesis.
Fiercely debated is an understatement.
Yeah. I mean, the reality is no single theory covers all the bases here. You are always looking at a combination of mechanisms.
Definitely.
But you have to start with Sampson's theory of retrograde menstruation, right? From 1927, which is still kind of the cornerstone.
It is the absolute classic theory.
The mechanics are simple. During menses, blood doesn't exclusively flow downward through the cervix. A portion of it flows backward, up through the fallopian tubes, and spills directly into the peritoneal cavity.
Carrying inviolable endometrial fragments with it.
Exactly.
And it's elegant in its simplicity. It perfectly explains why the pouch of Douglas and the ovaries are prime targets, due to gravity and proximity to the fimbriae.
Right.
It also seamlessly explains why teenagers with genital outflow tract obstructions, like an imperforate hymen, are at such a massive risk.
Oh, sure.
Because if the blood meets a physical barricade below, the pressure forces it entirely retrograde.
But wait, I have to completely push back on Sampson's theory being the sole primary driver.
Go for it.
If you look at the broader physiological data, retrograde menstruation is a nearly universal phenomenon. Well over 90% of women experience backward flow.
Yes, almost everyone.
So if throwing seeds into the pelvis is all it takes, why doesn't every single menstruating human develop endometriosis?
Right.
There has to be a missing piece of the puzzle here.
And that is the exact paradox researchers grapple with, and it brings you straight to the genetic and immunological factors.
The fertile soil argument.
Exactly. You have to look at the soil. In a normal immune system, retrograde menstrual blood is instantly recognized as debris.
Right, the body knows it shouldn't be there.
Your peritoneal macrophages sweep in and phagocytize those extruded cells. They destroy them and clear them out.
So the cleanup crew just does its job.
Usually, yes. But in a patient with endometriosis, that exact same cleanup crew completely fails.
Why?
Worse than failing, they actually become complicit. You see a documented failure of immune destruction coupled with these highly altered hyperactive macrophages in the peritoneal fluid.
Hyperactive in a bad way.
Yes. Instead of attacking the rogue cells, these hyperactive macrophages start secreting the very growth factors and cytokines that promote the implantation and proliferation of the endometriosis.
Oh, yeah.
The immune system is basically chemically tricked into nurturing the invader.
It's like the security system not only ignoring the burglar, but actively handing them the blueprints and a flashlight.
That's a great way to put it.
And the genetic data backs this up too. You have a 7% risk in first-degree relatives. You see deletions on chromosome 17, aberrant expression of HOX10 genes, and an overexpression of matrix metalloproteinases.
These MMPs.
Yeah. And these MMPs are crucial. They're the enzymes that allow the rogue cells to chew through the healthy extracellular matrix and anchor themselves in.
And once they anchor, they secure their own future.
How so?
There is a profound upregulation of local tissue aromatase activity within these lesions.
Aromatase that synthesizes estrogen, right?
Exactly. So these implants do not just wait passively for the ovaries to release hormones. They manufacture their own private, localized supply of estradiol.
They make their own fuel.
Yes, to fuel their own growth.
Yeah.
Add to that a localized resistance to progesterone, which normally acts as the brake pedal to estrogen's gas pedal, and you have a self-sustaining, unstoppable cellular engine.
Okay, so that perfectly explains the pelvic colonization.
Yeah.
You have the backward flow, the immune failure, the local estrogen factories.
Right.
But Samson's theory completely falls apart when you look at the lungs and the nose.
It does. It can't explain that at all.
So to explain those, you have to look at coalomic metaplasia, originally proposed by Meyer and Ivanov.
This is a really fascinating mechanism.
Yeah.
The pelvic peritoneum is derived from coalomic epithelium, which retains multi-potential capabilities.
Meaning it can change into other things.
Exactly. The theory argues that under chronic irritation, perhaps from the inflammatory soup of retrograde blood, this tissue undergoes metaplasia.
It shapeshifts.
It does. It spontaneously shapeshifts, transforming from normal peritoneum directly into endometrial tissue.
Wow.
And this elegantly explains lesions on the abdominal viscera or the umbilicus in women with no history of retrograde flow whatsoever.
Then you have the purely mechanical direct implantation theory.
Right.
This one is entirely iatrogenic. So a surgeon performs a cesarean section or an episiotomy, and the scalpel or the suture needle physically drags viable endometrial cells into the muscular layers of the wound.
Where they implant and grow into a scar endometriosis. And for the truly remote, bizarre sites, like the lungs, the arms, the thighs, you rely on Halban's lymphatic and vascular theory from 1925.
Okay, what's the argument there?
This argues that the endometrial tissue literally metastasizes. It invades the local lymphatic channels and blood vessels and is pumped throughout the body exactly like a carcinoma.
That is terrifying.
It is. And we know pelvic lymph nodes are involved in up to 30% of advanced cases, so the highway is definitely being used by these cells.
So regardless of how they get there, whether they spill backward, shapeshift, hitch a ride on a scalpel, or surf the lymphatic system, once they survive the immune system, what exactly are they building?
Well, if you analyze the pathology, you see the architectural wreckage this disease leaves behind.
Right, is the damage.
The defining pathological feature is how this ectopic tissue responds to cyclic ovarian hormones. You see the classic proliferative changes. The tissue thickens and swells as estrogen rises.
Just like it does in the uterus.
Exactly. But importantly, the secretory changes that normally occur under progesterone to prepare a lining for an embryo are conspicuously absent.
Why is that?
You are dealing with a localized steroid receptor deficiency.
So it aggressively thickens, but it doesn't mature properly.
Right.
And then when the cycle ends and the hormone levels crash, the tissue bleeds.
Yes.
But unlike a normal uterus that has a cervix to expel the blood out of the body, this bleeding is entirely encysted. It's trapped inside the peritoneal cavity or inside an organ.
And you just cannot overstate how intensely irritating free blood is to tissue outside the vascular system.
Hates it.
It absolutely hates it. When that blood pools cyclically, it triggers a massive, dense tissue reaction.
Right.
The body tries to wall it off with fibrosis, leading to immense scarring and dense adhesions binding the pelvic organs together.
Cementing them together.
Yeah, and when this fibrotic infiltration penetrates deeper than 5 millimeters beneath the peritoneal surface, you are dealing with deep infiltrating endometriosis, or DIE.
The visual of this is just brutal. It's like having an internal room that furiously floods every single month, but there is no drain.
That's exactly what's
The
happening.
water just stagnates, and the intense inflammatory reaction rots the surrounding architecture. You get these incredibly dense, thick bands of scar tissue pulling the uterus, the bowels, and the ovaries into a frozen block.
A frozen pelvis, exactly.
Yet, astoundingly, despite all this architectural devastation, the fallopian tubes usually remain completely patent.
They stay open.
Yeah, they stay open, which is wild.
But that is a crucial clinical nuance.
Oh, so.
The tubes may be patent, meaning fluid can technically pass through them, but their delicate spatial orientation is entirely destroyed.
Oh, I see.
For a tube to pick up an ovum, the fimbriae have to sweep freely over the ovary.
Like a vacuum.
Right. But when massive adhesions lock the tube and ovary into immovable positions, patency is completely irrelevant. The mechanics of conception are broken.
And when this bleeding process happens inside the tough capsule of the ovary, you get the formation of ovarian endometriomas.
Right.
With every cycle, the encysted tissue bleeds into the center of the ovary. The cyst expands. Between cycles, the watery serum portion of the blood is reabsorbed, leaving behind this thick, dark, degraded, tar-like blood pigment.
Which is universally known as the chocolate cyst.
Right, because of the color.
Yeah, though clinically you must prefer the term endometrioma. A hemorrhagic corpus luteum cyst can also look like chocolate when it ruptures, but it has an entirely different pathology.
Okay, that's an important distinction.
Very important. If you biopsy these endometriomas, you are looking for 3 microscopic hallmarks:
What are they?
endometrial glands, endometrial stroma, and pseudoxanthoma cells.
Pseudoxanthoma cells.
Yeah, these are essentially massive hemosiderin-laden macrophages, immune cells that have gorged themselves on the rusted iron of the old trapped blood.
Ah, okay, that makes sense. And if a surgeon is looking at this via laparoscopy, the visual presentation is widely varied, right?
Oh, extremely varied.
You have the early subtle lesions that look like clear papules or vesicles. But the classic presentations, particularly in the pouch of Douglas, are these puckered black dots.
Yes.
They're literally described as powder burns or matchstick spots.
You also see white peritoneal areas, yellow-brown patches, and critically red, flame-shaped or polypoid areas.
Flame-shaped areas.
Yeah, and this is a massive pathological distinction.
Why?
Those bright red, flame-shaped, blood-filled lesions are biochemically much more active than the classic black powder burns.
Okay, so color matters.
Hugely. The black spots are effectively the burned-out fibrotic remnants of old disease. The red spots are the highly vascularized active fires producing the massive inflammatory response.
Which translates immediately into the patient's lived experience. You have this micro-level chemical warfare that completely dictates the clinical features.
Absolutely.
When you look at the patient profile, you are typically seeing women between 30 and 45, highly correlated with being nulliparous,
Yep.
and often tied to a higher socioeconomic status, which honestly likely just reflects the access to delayed family planning and expensive diagnostic workups.
That's a very fair assessment. But here you hit the most baffling clinical paradox of the entire disease.
The symptoms.
Yes, roughly 25% of these patients are entirely asymptomatic.
Entirely.
Yes. You can open a patient up for a routine tubal ligation and find her pelvis absolutely obliterated by dense adhesions and widespread powder burns, and she has never felt a day of pelvic pain in her life.
That just defies logical engineering to me.
It really does.
How can your pelvis be cemented together with scar tissue and you feel nothing, while another patient has a single 6-millimeter spot on her uterosacral ligament and she is bedridden with agony?
It's the primary question patients ask.
The data is extremely clear on this, though. The severity of symptoms has absolutely zero correlation with the widespread extent of the disease.
None at all. The symptoms correlate strictly with 2 things: the depth of penetration and the biochemical activity of the specific lesion.
Okay, break that down for me.
If a lesion penetrates deeper than 5 millimeters into the subperitoneal space, it inevitably invades nerve fibers, causing excruciating pain.
Right. DIE.
Yes. Furthermore, those highly active, non-pigmented red lesions we discussed, they secrete exponentially higher levels of prostaglandin F, or PGF.
And prostaglandins are the exact lipid compounds that trigger smooth muscle contraction and pain signaling.
Exactly.
So a tiny hyperactive red lesion is functioning as a microscopic factory, basically flooding the local nerves with chemical pain amplifiers,
Right.
while a massive, old black lesion is just sitting there inertly doing nothing.
Exactly. And when you look at the actual symptom breakdown, dysmenorrhea is the overwhelming complaint, hitting 70% of symptomatic patients.
Painful periods.
Yes, but you have to distinguish this from primary dysmenorrhea.
That's the difference.
Primary dysmenorrhea is the standard physiological cramping many adolescents experience, which often resolves or improves over time. Endometriosis causes a progressively severe secondary dysmenorrhea.
You see a very specific temporal pattern with this, don't you?
You do.
It typically starts after years of relatively pain-free cycles. The pain initiates a few days before the actual menses begins, ramps up severely during the flow, and crucially lingers long after bleeding has stopped.
Yes.
It is a deep-seated comenstrual ache that radiates into the back, the pelvis, and the rectum.
And it is driven directly by those ectopic implants secreting high levels of prostaglandin F2 alpha and thromboxane B2, chronically inflaming the local nerves.
Beyond the pain, 15 to 20% of patients present with abnormal uterine bleeding, usually menorrhagia.
Heavy bleeding. Yeah.
And if the ovarian architecture is heavily disrupted by endometriomas, it can alter the cycle length itself, causing polymenorrhea.
Right.
Then you have dyspareunia, affecting 20 to 40%.
And it's vital to specify that this is deep dyspareunia.
Right, pain during intercourse.
Yes, but this is not pain at the vaginal entrance.
Oh.
If you think back to our anatomical mapping, the pouch of Douglas and the uterosacral ligaments are sitting right at the apex of the vagina.
The deepest part.
Exactly. If those tissues are rigid, inflamed, filled with highly innervated nodules, or if the uterus is glued backward in a fixed retroverted position.
Any deep penetration is going to mechanically stretch and tear at those actively inflamed nerves.
It's pure mechanical tension on inflamed tissue.
Ouch.
And all of this culminates in a state of chronic pelvic pain. You have continuous peritoneal inflammation from the cytokine soup.
Right.
Localized tissue necrosis from the insisted blood breaking down, sheer structural tension from adhesions pulling organs out of place, and direct compression from the physical mass of large endometriomas.
To really ground how devastating this cascade can be, you just have to look at the documented case history in the text.
Ah, yes, Mrs. CR.
Right, Mrs. CR. A 43-year-old woman. She presents with persistent pelvic pain radiating to her back, but she also starts developing recurrent pyelonephritis.
Severe acute kidney infection.
Yeah. And from a purely gynecological standpoint, kidney infections seem totally unrelated.
They really do.
But when you image her with an MRI, you find stage IV deep infiltrating endometriosis. Both ovaries are involved.
Right.
But the catastrophic finding is that the fibrotic scarring from the endometriosis has completely choked off her right ureter at the pelvic floor.
Enclosed it in scar tissue.
Yeah, the tube carrying urine from her kidney to her bladder is encased in concrete.
The MRI reveals massive hydronephrosis and hydroureter.
Which means
Her right kidney and ureter are literally ballooning under the pressure of backed-up urine, destroying the renal tissue.
wow.
And the surgical intervention required for this is massive.
What do they have to do?
She undergoes a full laparotomy, a total hysterectomy, a bilateral salpingo-oophorectomy to remove all estrogen production.
Yeah.
And they literally have to cut out a 4-centimeter heavily scarred section of her ureter and reimplant the healthy proximal end directly into her bladder.
Just to save her kidney. It flawlessly illustrates the invasive aggressive nature of the disease. What begins as microscopic rogue cells on the peritoneum can quietly infiltrate and destroy the surrounding urological or gastrointestinal systems.
Escalating into a multi-organ, life-altering surgical crisis.
And because the presentation can range from entirely asymptomatic to catastrophic kidney failure, the diagnostic journey is incredibly fraught.
It's minefield.
How do you actually confirm what you are looking at? You usually start with the classic triad, right?
Yes. Progressively increasing secondary dysmenorrhea, dyspareunia, and infertility.
But even if the clinical suspicion is high, the physical examination is notoriously unreliable.
Oh, the sensitivity and specificity of a bimanual exam are incredibly poor.
You just can't feel it.
Sometimes you can. In advanced cases, you might palpate nodularity along the uterosacral ligaments, or feel a rigidly fixed retroverted uterus, or tender adnexal masses if there are large chocolate cysts.
Right.
But in the vast majority of patients with superficial but highly active disease, the physical exam reveals absolutely nothing.
So you naturally turn to blood tests. You look for serum markers. CA-125 is the most frequently discussed.
It is.
And yes, CA-125 levels are moderately elevated in severe endometriosis, but it is fundamentally a non-specific marker.
Exactly.
It is the primary tumor marker for epithelial ovarian carcinoma. If it's elevated, you could be looking at endometriosis, ovarian cancer, PID, or severe fibroids.
You absolutely cannot use it to establish a definitive primary diagnosis.
So what do you use it for?
Its primary utility is longitudinal. You use CA-125 to assess the therapeutic response, did the levels drop after a course of medical oophorectomy, and to monitor for postoperative recurrence.
Are there other markers?
There are other markers like monocyte chemotactic protein 1 and glycodelin that show elevations, but their levels fluctuate so wildly across the cycle that they are totally useless for routine clinical diagnosis.
Which pushes the entire diagnostic burden onto imaging.
Yes, it does.
Transvaginal ultrasound, or TVS, is highly accessible and exceptional for spotting ovarian endometriomas. It detects those classic thick-walled cysts with a homogeneous low-level echo pattern.
Often called a ground glass appearance.
Right, but TVS is practically blind to superficial peritoneal implants. You cannot see the powder burns or the red flame lesions causing all the pain.
Exactly. For comprehensive mapping, magnetic resonance imaging is the undisputed best non-invasive tool.
The MRI.
Yeah, MRI gives you a 91 to 95% sensitivity and specificity, and it is absolutely vital for identifying deep infiltrating endometriosis before you ever make a surgical incision.
And the physical mechanics of why MRI works so well here are just brilliant.
They are.
You're looking for a very specific signature. Hyperintensity on T1 weighted images paired with hypointensity or shading on T2 weighted images.
Right.
And this isn't just arbitrary contrast. As that trapped cyclic blood inside the cyst degrades over months, the hemoglobin breaks down into methemoglobin and hemosiderin.
The iron compound.
Yes. These highly concentrated iron-heavy degradation products interact with the magnetic fields, causing the cyst to light up like a beacon on T1 and turn starkly dark on T2.
You are literally using magnetic resonance to detect the rust left behind by internal bleeding.
Which is a phenomenal application of physics.
Truly.
But even with a perfect MRI, non-invasive imaging cannot definitively diagnose superficial peritoneal disease.
No, it can't.
Therefore, the absolute gold standard remains the double puncture laparoscopy. You have to physically look inside the abdomen.
You do. Laparoscopy provides immediate visual confirmation. The surgeon maps the exact site, size, and extent of the lesions, evaluates the severity of the adhesions, and takes targeted biopsies for histological confirmation.
And this brings up a critical clinical caveat regarding histology.
Yes.
Finding endometrial glands and stroma under the microscope is the definitive proof. However, negative histology does not exclude the disease.
And that's so important for patients to understand.
Why does it happen?
When a surgeon biopsies a dense fibrotic nodule, the actual active endometrial cells might be microscopic islands buried within a massive sea of scar tissue.
So they just miss it.
Exactly. The biopsy needle can easily miss the active cells, returning a negative pathology report despite the disease being aggressively present.
Which sparks a huge debate about empiric medical treatment.
It really does.
Because laparoscopy is a surgical procedure with inherent risks, many clinicians want to just prescribe a heavy course of continuous hormones based on symptoms alone.
Right. Skip the surgery.
But because the symptoms overlap with so many other conditions, relying purely on empiric treatment without seeing the pelvis is generally not recommended unless the sole goal is basic pain management and reducing menstrual flow.
Because if you just throw hormones at pelvic pain without looking, you might be missing a completely different acute crisis.
Like what?
Well, the differential diagnosis for endometriosis is a terrifying lineup of surgical emergencies.
Right. You are constantly trying to differentiate a painful endometrioma from a benign or, frankly, malignant ovarian tumor.
Yes.
But the real crisis occurs when a chocolate cyst ruptures.
Oh, absolutely.
During surgery, separating dense adhesions almost always tears the cyst wall, spilling that thick, tarry, chocolate-like material. But these cysts can also rupture spontaneously while the patient is just going about her day.
And when a large endometrioma spontaneously ruptures, it floods the peritoneal cavity with highly concentrated degraded blood products.
Which hurts.
The chemical irritation to the peritoneum is instantaneous and excruciating. The clinical presentation is an acute abdomen-rigid, guarding, severe pain.
It perfectly mimics a ruptured ectopic pregnancy, acute appendicitis, torsion of an ovarian cyst, or a catastrophic pelvic inflammatory infection.
All surgical emergencies.
You cannot differentiate these clinically in an emergency room. You have to perform an emergency laparoscopy to figure out what just exploded.
And aside from the acute risk of rupture, the long-term complications are severe. You have the risk of the cyst becoming secondarily infected. You have the bowel and ureteral obstructions we saw with Mrs. CR. And crucially, there is a documented fourfold increase in the risk of developing endometrioid ovarian cancer later in life.
But the complication that defines the disease for a huge portion of patients is infertility.
Unquestionably.
We touched on this, but it's a multi-front war. It is not just the physical distortion of the fallopian tubes.
Yeah.
Even if the anatomy is perfectly preserved, the environment is toxic.
The inflammatory peritoneal fluid completely disrupts the normal oovocyte-sperm interaction.
Oh, exactly.
You have a massive proliferation of hyperactive macrophages in the pelvis, and these immune cells actively engage in sperm phagocytosis.
They eat the sperm.
They literally consume the sperm before it can ever reach the egg.
And on the ovarian side, the localized inflammation and the physical presence of endometriomas cause anovulation, oligoovulation, and a luteal phase defect.
Right.
The ovarian reserve is directly diminished by the disease itself, and ironically, further diminished by any surgical attempt to remove the disease.
It's a catch-22.
And even if an embryo manages to form, the uterus itself is compromised. You see reduced endometrial receptivity, implantation failures, and a localized resistance to progesterone that drives early miscarriages.
It is a blockade at every single step of human reproduction.
So to navigate this chaos, the medical community relies on staging systems to quantify the wreckage.
Yes, to try and make sense of it.
The Revised American Fertility Society, or AFS scoring system, is the standard. It assigns points based strictly on laparoscopic findings.
Right.
The surgeon scores the superficial and deep lesions on the peritoneum and ovaries, calculates the obliteration of the posterior cul-de-sac, and evaluates whether the adhesions are filmy or dense.
And the point thresholds are rigid. Stage 1 is minimal disease, 1 to 5 points. Stage 2 is mild, 6 to 15 points. Stage 3 is moderate, 16 to 40 points. And stage 4 is severe, anything over 40 points.
Okay.
Just for context, if a surgeon sees that the fimbriated end of the fallopian tube is completely encapsulated by dense adhesions, that single finding is an automatic 16 points.
Wow, straight to stage 3.
Exactly. The theoretical objective of staging is to predict the prognosis, guide the therapeutic choices, and standardize the evaluation of different treatments.
Theoretical.
Yes, theoretical, because the practical limitations of the AFS staging are massive and widely acknowledged.
Yeah, I have to push back hard on the utility of this staging.
Go ahead.
You require an invasive surgery just to calculate the number. It suffers from massive inter-observer variation. Two highly skilled surgeons looking at the same pelvis will routinely calculate different scores.
That's very true.
And most damningly, the score has absolutely zero correlation with the patient's pain levels. It does not reliably predict fertility outcomes, and it does not dictate the optimal mode of therapy.
Right.
So why do we even use it? Is it purely academic?
It is a highly valid frustration. The AFS system is purely morphological. It meticulously maps the macroscopic physical damage, the scarring, the cysts, the obliteration.
What it can see.
Exactly. But it completely ignores the biochemical, immunological, and microscopic reality of the disease. It doesn't measure the prostaglandin output of those tiny, invisible red lesions that are causing 90% of the pain.
Right.
However, accurately mapping the physical stage, particularly the extent of deep infiltrating disease and the size of the endometriomas, is crucial when you sit down to design the highly customized management spectrum.
Which transitions us directly into how you actually fight this. The management spectrum is wide, ranging from simple observation to heavy hormonal suppression.
Right.
You are chasing three primary goals. Abolish or minimize the pain, improve or preserve fertility, and prevent recurrence.
And recurrence is a monster.
Yeah, you are looking at a 40% recurrence rate within 5 years of treatment.
Because there is no universal cure, the therapeutic approach must be intensely individualized. You have to weigh the patient's age, the specific location of the lesions, her immediate desire for fertility, and the severity of her daily symptoms.
Yeah.
And for a very specific subset of patients, the first line of management is entirely expectant. You just observe.
Recommending observation for a disease that actively progresses in 30 to 60% of women sounds like medical negligence.
It does sound counterintuitive.
But the criteria is very strict. Right?
Very strict. You are looking at young, unmarried women or young married women actively ready to start a family, or perimenopausal women who only have minimal disease and absolutely no other abnormal pelvic findings.
In these specific cases, you manage the pain with NSAIDs prostaglandin inhibitors like ibuprofen or mefenamic acid to counteract the chemical inflammation.
Yes.
But the definitive advice for married women in this category is to conceive as early as possible. Pregnancy is a profound natural suppressor of the disease.
It is. The physiology of pregnancy is the exact opposite of what the endometriosis needs.
How so?
You get a massive sustained influx of progesterone and a complete cessation of cyclical estrogen spikes and shedding. This hormonal environment forces the ectopic endometrial tissue to undergo decidual changes, followed by necrosis and eventual absorption. The body basically starves it out naturally.
But for the vast majority of patients, those who cannot conceive, do not want to conceive, or whose disease is too advanced, you have to intervene medically.
Yes.
And the golden rule of medical management is understanding that endometriosis is fundamentally an estrogen-dependent disease.
Exactly.
The entire goal of hormonal therapy is to induce profound atrophy of the ectopic implants by ruthlessly cutting off their estrogen supply.
But you have to be radically honest with the patient here. Hormonal treatment is exclusively suppressive, not curative.
Doesn't cure it.
No. The minute you withdraw the hormones, the estrogen returns, the lesions reactivate, and the disease typically comes roaring back.
Right.
The mechanics of this suppression revolve around tricking the brain and the ovaries into one of three physiological states:
Which are?
pseudopregnancy, pseudomenopause, or a complete medical oophorectomy.
Let's look at the mechanics of pseudopregnancy. You achieve this using continuous combined oral contraceptive pills, or COCs, or targeted progestogens.
Yes.
By taking them continuously, you eliminate the menstrual cycle entirely. The constant high-dose progestin forces the ectopic tissue to decidualize, and without the cyclic spikes of estrogen to signal growth, the tissue eventually exhausts itself and atrophies.
And the data strongly highlights Dianogest for this, which is a 19-nortestosterone derivative.
Okay.
It is highly effective at just 2 milligrams a day. What makes Dianogest remarkable is that it doesn't just stop ovulation and cause tissue atrophy. It is a selective progestin that actively inhibits the localized secretion of cytokines.
Wow.
Yeah, and it physically decreases the nerve fiber density within the endometriotic lesions.
So it's actively reducing the pain wires.
Exactly. It is aggressively targeting both the growth and the pain signaling simultaneously.
That's incredible.
Alternatively, using a levonorgestrel-releasing IUS, like a Mirena, provides immense localized progestin suppression, which is highly effective for deep rectovaginal disease.
But if pseudopregnancy fails, you escalate to pseudomenopause, primarily using danazol.
Yes, Darzol.
Danazol is an isoxazole derivative of 17-alpha-ethanol testosterone. It is a synthetic androgen.
Right.
It works by aggressively shutting down the pituitary-ovarian axis, halting the production of FSH and LH.
Yeah.
You dose it at 400 to 600 milligrams daily, which must be high enough to induce complete amenorrhea.
It is highly effective, inducing clinical resolution in about 80% of cases. But the metabolic cost to the patient is severe.
Because it's an androgen.
Yes.
Yeah.
Because it is an androgen, the side effects are essentially masculinizing. You see significant weight gain, severe acne, hirsutism, and a deepening of the voice.
Wow.
And alarmingly, some of these androgenic changes, particularly the voice changes, can be irreversible even after you stop the drug.
Furthermore, it requires absolute adherence to barrier contraception during treatment, right?
Absolutely mandatory.
Because it is highly androgenic. If a patient accidentally conceives while on danazol, it will cause severe virilization of a female fetus.
Yes. Gestrinone is an alternative in this class. It has similar anti-estrogenic and anti-progestogenic mechanisms, but requires dosing only twice a week, slightly improving the side effect profile.
But the true heavy artillery of medical management is the medical oophorectomy.
The big guns.
This is achieved using gonadotropin-releasing hormone, or GnRH, analogs like leuprolide, triptorelin, or goserelin.
The pharmacological mechanism here is brilliant but brutal.
How does it work?
Normally, your hypothalamus releases GnRH in precise pulses to stimulate the pituitary gland. GnRH agonists flood the system, delivering a massive, continuous dose.
Okay.
Initially, the pituitary goes into overdrive, but very quickly it completely burns out. It downregulates its own receptors.
It's jipped up.
Exactly. This triggers a profound systemic drop in estrogen, creating a state of immediate chemical hypoestronism, a temporary menopause.
The clinical target is to crash the serum estrogen levels down to a very specific window, between 30 and 45 picograms per milliliter.
The therapeutic window.
Yeah. This is the exact window where you are starving the endometriosis to death, but keeping just enough baseline estrogen to prevent catastrophic bone demineralization.
Right.
But there is a massive caveat with these agonists. The dreaded flare effect.
Ah, the flare effect. Because the agonist initially overstimulates the pituitary before burning it out, the first week or two of treatment causes a massive surge in estrogen and gonadotropins.
Like a last hurrah.
Yes. This sudden spike acts like throwing gasoline on the endometriosis, causing a severe, agonizing flare-up of the patient's symptoms before the suppression finally kicks in.
Which is exactly why the newer pharmacological developments, the GnRH antagonists like oral elagolix, are changing the landscape.
They really are.
An antagonist doesn't overstimulate the receptor, it just immediately blocks it.
Right.
You get instantaneous suppression.
Right.
There is absolutely zero flare effect, and the data shows it causes significantly less bone demineralization and fewer vasomotor symptoms like hot flashes compared to the agonists.
Regardless of whether you use an agonist or antagonist, long-term use requires add-back therapy.
Add-back therapy.
Yes. You are inducing menopause in a 30-year-old woman. You have to give back a microdose of estrogen or progestin,
Just a little bit.
just enough to protect her bone density from osteoporosis and mitigate the severe hot flashes, but staying strictly below the threshold that would reactivate the endometriosis implants.
You also have to counter the fact that these rogue implants can make their own estrogen.
Right, the aromatase.
This brings in aromatase inhibitors like letrozole or anastrozole. As we detailed in the pathogenesis, the lesions upregulate aromatase to synthesize local estradiol. Aromatase inhibitors directly neutralize this local factory.
They shut it down.
However, in premenopausal women, dropping estrogen this way causes the pituitary to panic and hypersecrete gonadotropins, which can stimulate massive ovarian cysts.
Yes, that's a big risk.
So you almost always have to co-administer them with a COC or a progestin to keep the ovaries quiet. You also see research into selective progesterone receptor modulators like esoprisonol and even statins to inhibit cell proliferation.
But when you synthesize all the data across all these medications, balancing pain relief, side effects, and subsequent pregnancy rates, no single chemical therapy demonstrates massive superiority over the others.
There's no magic pill.
No. And invariably, you hit a wall. When the pain breaks through the hormones, when the side effects become intolerable, or when the pelvic anatomy is structurally destroyed by massive endometriomas and concrete adhesions, chemical warfare is useless.
You have to physically extract the disease.
Exactly. This is the domain of surgical management.
Surgery is strictly indicated for severe intractable symptoms.
Yeah.
Deep infiltrating endometriosis that is actively distorting the anatomy, severe adhesive disease, and ovarian endometriomas larger than 1 centimeter.
Though the exact surgical thresholds depend heavily on the patient's goals.
Right. And surgery broadly splits into two philosophies, conservative and definitive.
Conservative surgery is an incredibly delicate tightrope walk. The goal is to aggressively destroy every visible ectopic lesion, alyse the adhesions, and restore the normal pelvic anatomy, while absolutely preserving the uterus and functional ovarian tissue to allow for future reproduction.
Which is hard to do.
Very hard. Laparoscopy is the mandatory approach, utilizing electrodiathermy or laser vaporization.
Laser vaporization offers a distinct critical advantage in these specific surgeries. The CO2, or argon laser, allows the surgeon to cut and vaporize tissue with microscopic precision.
Yes.
The thermal spread, the collateral heat damage to surrounding tissue is minimal. This is paramount when you are trying to vaporize an implant that is sitting 1 millimeter away from the ureter or the bowel wall.
For patients suffering from severe central pelvic pain that is unresponsive to other treatments, surgeons might perform targeted nerve destruction.
Not in nerves.
Yes. A presacral neurectomy, or PSN, or a laparoscopic uterosacral nerve ablation, or L-LUNA. They literally sever the specific nerve pathways that transmit the pain signals from the pelvic organs up to the brain.
So you aren't removing the disease, you are just cutting the alarm wires.
Exactly. But the most agonizing surgical decisions revolve around the ovaries.
Right.
If you have a small endometrioma, under 3 centimeters, the surgeon can laparoscopically aspirate the fluid, irrigate the cavity, and vaporize the inner wall.
Easy enough.
But if the cyst is massive, greater than 4 centimeters, simple drainage is useless. It requires a full cystectomy. The surgeon has to physically peel the thick fibrotic cyst wall entirely off the healthy ovarian tissue.
And if you look at the reproductive implications, this is a brutal catch-22.
It really is.
That fibrotic cyst wall is intimately adhered to the healthy ovarian cortex. Stripping it away invariably tears away thousands of healthy primordial follicles.
Yes.
A bilateral cystectomy catastrophically reduces the patient's ovarian reserve.
It does.
A young woman is forced to weigh an impossible choice. Undergo the surgery to remove the massive toxic cyst and stop the agonizing pain, knowing it might permanently destroy her egg supply.
Or leave the cyst in place, knowing its very presence is actively destroying the ovary and creating a toxic environment that prevents conception anyway.
It is a devastating, life-altering calculus for patients who have completed their families or whose disease has progressed so far that fertility is permanently destroyed. You transition to definitive surgery,
The nuclear option.
a total hysterectomy with bilateral salpingo-oophorectomy, the complete removal of the uterus, both fallopian tubes, and critically, both ovaries, to permanently eliminate the endogenous estrogen supply.
During definitive surgery, the surgeon must also aggressively resect all visible endometriotic tissue throughout the pelvis, which frequently necessitates resecting portions of the bowel or the ureters.
Just clean it all out.
Yes, it is a massive, highly invasive procedure, but the data is undeniable. It provides definitive symptom relief in over 91% of cases.
In clinical practice, you rarely see surgery isolated from medical management. It's usually a combined therapy. The clinician might prescribe a GnRH analog for 3 to 6 months preoperatively. This chemical suppression shrinks the lesions, massively reduces their vascularity, and decreases the pelvic inflammation, making the subsequent surgery significantly safer and reducing blood loss.
Right.
Postoperatively, hormones can suppress any microscopic remnants the surgeon couldn't see, though you obviously avoid postoperative hormones if the patient's immediate goal is to utilize her newly restored anatomy to get pregnant.
And you cannot discuss surgery without addressing those bizarre extrapelvic sites.
The distant ones.
Yeah. Treating endometriosis in remote organs is like fighting a hydra. You can perfectly clear the pelvis only to have the disease manifest in the chest cavity.
If a patient has thoracic endometriosis, she can present with catamenial hemoptysis,
Yeah.
literally coughing up blood in perfect synchronization with her menstrual cycle.
Yes.
If the lesions are on the pleura, she can suffer a catamenial pneumothorax, where the cyclical bleeding causes her lung to spontaneously collapse every month.
Terrifying.
Hormonal suppression is the first line, but if it fails, a thoracic surgeon has to physically resect the affected lobe of the lung. In older patients, removing the ovaries might be the only way to permanently shut down the pulmonary lesions.
Scar endometriosis is equally stubborn. You get a painful, hyperpigmented nodule in a C-section scar that physically swells and bleeds during menses.
And hormones work for that.
Actually, no. Hormonal therapy is almost universally useless because the dense scar tissue prevents the drugs from penetrating. It requires a wide surgical excision of the abdominal wall.
The urological involvement is incredibly dangerous, too.
Oh, yeah.
If the disease infiltrates the bladder wall, the patient suffers cyclic dysuria, extreme urinary frequency, and hematuria.
Blood in the urine.
Right. A cystoscopy will reveal these distinct blue cystic lesions on the bladder mucosa. Again, hormones rarely provide definitive relief. The surgeon has to excise that full-thickness portion of the bladder wall or perform complex urethral resections like we saw with Mrs. CR.
And finally, bowel involvement, usually the rectum or sigmoid colon.
What happens there?
The patient experiences dyschezia, which is excruciatingly painful defecation or, frankly, bleeds from the rectum during menstruation. But there's a vital pathological distinction here.
What is it?
The actual inner mucosa of the gut is almost never involved. The endometriosis attacks the bowel from the outside in, infiltrating the serosa and muscularis layers.
Oh, I see.
This fundamentally differentiates it from an intrinsic colon cancer. If hormones fail, it requires a full segmental bowel resection and anastomosis.
We have spent an immense amount of time tracking this rogue tissue as it explodes outward, colonizing the pelvis, the lungs, the bladder, the scars.
May have.
But what happens when the endometrium doesn't travel outward? What happens when it turns its aggressive, invasive nature strictly inward and burrows straight down into the muscular wall of its own home?
That transitions us into the internal counterpart of this disease, adenomyosis.
The adenomyosis, historically termed endometriosis interna, is defined by the direct ingrowth of the functioning endometrium, both the glands and the stroma deep into the myometrium, the thick, smooth muscle wall of the uterus.
And right away, the epidemiological profile shifts dramatically.
How so?
Endometriosis is classically a disease of young, nulliparous women. Adenomyosis is overwhelmingly a disease of multiparous women, women who have given birth multiple times.
Okay.
And it typically presents much later, usually in women over the age of 40, though it's vital to note that it coexists with standard pelvic endometriosis in about 40% of surgical cases.
The suspected causes point heavily toward mechanical and hormonal trauma over time. repeated pregnancies and childbirths, vigorous mechanical curettage from multiple D&C procedures, and a state of chronic estrogen excess are the primary drivers.
The pathogenesis centers entirely on the structural integrity of the endometrial-myometrial interface, or EMI.
Right, the boundary.
In a normal uterus, there is no protective submucosal layer. The fragile endometrial lining sits in direct physical contact with the dense muscular wall.
When you image this on an MRI, you see a highly specific anatomical boundary called the junctional zone, or JZ. It appears as a distinct low-signal intensity band. The prevailing pathological theory is that adenomyosis begins when this junctional zone is compromised.
It breaks down.
Whether it's broken mechanically by a surgical instrument, weakened by genetic predisposition, or altered by an abnormal local immune response, the barrier fails. The endometrial glands simply exploit the breach and grow relentlessly downward into the muscle fibers.
And the muscle does not tolerate this invasion passively.
What does it do?
As these ectopic endometrial nests establish themselves deep within the uterine wall, the surrounding myometrium reacts defensively. It undergoes massive myometrial hyperplasia.
It thickens.
Yes, it's a rapid, localized overgrowth of the smooth muscle tissue attempting to wall off the invading glands. This results in a heavy, diffuse, symmetrical enlargement of the entire uterus, though the posterior wall is typically much thicker than the anterior.
You have to perfectly contrast this with uterine fibroids, which are the other massive cause of an enlarged, bulky uterus.
It's a critical distinction.
A fibroid is a distinct, localized neoplasm. It is a solid ball of muscle that develops a very clear, white pseudocapsule around it.
Right.
A surgeon can literally slice into the uterus and shell a fibroid out as cleanly as plucking a pearl from an oyster.
But adenomyosis completely lacks a capsule. This is the defining pathological distinction.
There's no border.
Exactly. It is a diffuse, deeply trabeculated mass that is intimately woven into the normal muscle fibers. If you cut into an adenomyotic uterus, you don't see a discrete tumor. You see thickened, dark muscle punctuated by tiny cystic spaces and pinpoint blood spots.
From the bleeding.
Yes, where the trapped glands have been cyclically bleeding directly into the muscle.
And the biomechanical implications of that missing capsule are just catastrophic. Think about the physics of the organ. In endometriosis, the rogue tissue bleeds into the open space of the pelvic cavity.
Right.
In adenomyosis, the tissue is actively bleeding, swelling, and shedding inside the incredibly tight, confined layers of a muscle that is designed to contract violently every single month.
It creates a perfect storm of mechanical and vascular failure, which dictates the clinical presentation.
Right.
About 50% of cases might be found incidentally, but the symptomatic patients present with profound, debilitating menorrhagia, excessively heavy, and prolonged menstrual bleeding.
But heavy bleeding is multifactorial, right?
Yes.
First, because the uterus is globally enlarged by the hyperplasia, the overall surface area of the bleeding endometrial cavity is massively increased.
Yes.
Furthermore, the healthy muscle is so interrupted by these diffuse, swollen nests of adenomyosis that it physically cannot clank down. Inadequate uterine contraction means the spiral arteries stay wide open, leading to massive blood loss.
But the hallmark symptom affecting about 30% of patients is severe colicky dysmenorrhea.
Cramping.
And the physics of this pain are fundamentally different from standard cramping. During a normal period, the uterus uses organized antegrade contractions.
Meaning top down.
Exactly. The electrical signal starts at the fundus, the top of the uterus, and ripples downward in a coordinated wave to push the blood out through the cervix.
But the adenomyosis completely obliterates the junctional zone, which is where those electrical signals propagate.
So the signaling is totally scrambled.
Exactly. Instead of organized downward waves, the uterus begins firing retrograde contractions. The muscle fibers are spasming upward and firing against themselves.
It's terrible.
The uterus is essentially engaging in a violent, disorganized biomechanical civil war.
When you combine those chaotic retrograde contractions with localized tissue edema from the trapped microbleeds and the massive release of prostaglandins from the active tissue,
It hurts.
the result is an agonizingly tender, heavily engorged organ. The sheer bulk and tenderness of the uterus also perfectly explains why these patients suffer from severe deep dyspareunia and constant urinary frequency.
Because they have a heavy, inflamed mass constantly pressing against the vaginal vault and the bladder.
Exactly. And just like its external counterpart, adenomyosis aggressively drives infertility and early miscarriage.
Yeah.
The chaotic retrograde contractions physically interfere with normal sperm transport up to the tubes. The chronic subendometrial inflammation prevents a healthy blastocyst from implanting securely. You have altered nitric oxide pathways and that same hyperactive macrophage response, creating a locally toxic environment for reproduction.
So how do you diagnose a disease that is entirely hidden inside the wall of the organ?
It's tricky.
On a physical exam, you might palpate a uniformly enlarged, globally tender uterus. It feels firm, but it rarely exceeds the size of a 14-week pregnancy.
hmm
However, physical palpation cannot distinguish it from a diffuse fibroid uterus.
You really have to rely on advanced imaging.
Right.
A 3D transvaginal ultrasound utilizing color Doppler is highly effective. The sonographer is looking for the complete loss of that normal hypoechoic inner zone.
Okay.
Instead, the myometrium shows a heterogeneous echogenicity. The absolute classic sonographic sign is a Swiss cheese or honeycomb appearance.
Was cheap?
Yeah. You see dozens of tiny hypoechoic cysts scattered randomly throughout the muscle wall, alongside an ill-defined endometrial echo and violently increased vascularity on the Doppler.
But the definitive, non-invasive diagnostic standard remains MRI.
Unquestionably.
The MRI will clearly show the asymmetrical thickening of the walls, the heterogeneous trabecular texture, and those high-signal honeycomb cysts. It will also reveal distinct striated projections extending directly from the endometrium down into the muscle.
But the absolute diagnostic criteria for adenomyosis is a measured thickening of the junctional zone to 12 millimeters or greater.
Once you confirm that the muscle is infiltrated, you face the reality of treatment. And the data is incredibly blunt here. Standard medical management is generally highly unsatisfactory.
It usually fails.
You use heavy NSAIDs to manage the pain and try to reduce the bleeding. But standard oral cyclic hormones, or even continuous progestins, struggle immensely to penetrate deep enough into the dense, fibrotic muscle to effectively suppress the ectopic glands.
The only medical therapies that show significant efficacy are targeted, localized delivery systems.
Like what?
The levonorgestrel-releasing IUS, the Mirena, is placed directly inside the uterine cavity. It constantly bathes the endometrium and the immediate subendometrial layers in a highly concentrated dose of progestin.
Oh, that makes sense.
This massively reduces the menorrhagia and helps control the dysmenorrhea for many patients without relying on systemic absorption.
The data also highlights a very specialized targeted approach.
Yeah.
A danazol-loaded IUD.
Yes.
As we discussed earlier, oral danazol causes horrific virilizing side effects because it floods the entire body with synthetic androgens.
Right.
But a specialized IUD delivering 300 to 400 milligrams of danazol directly into the uterine lining shrinks the adenomyosis effectively without significantly elevating the systemic serum levels.
You get the aggressive local suppression without the voice deepening or the systemic virilization.
If localized medical management fails, the surgical options are severely limited.
They are.
Because adenomyosis lacks a capsule, conservative surgery is a technical nightmare. Performing an adenomyomectomy, attempting to surgically core out the diffuse, diseased tissue while leaving enough healthy muscle to reconstruct a functional uterus is technically daunting and frequently impossible.
Uterine artery embolization, or UAE, is a viable alternative for some.
How does that work?
By intentionally blocking the primary blood vessels feeding the uterus, you starve the entire organ of oxygen and nutrients. The adenomyotic tissue undergoes necrosis and shrinks, which can significantly relieve the heavy bleeding and the bulk symptoms.
But ultimately, the most effective and definitive treatment for adenomyosis, assuming the patient has completed her childbearing or the disease has advanced past the point of preservation, is a total hysterectomy.
Yes.
Because the disease is strictly confined to the uterus, removing the organ cures the disease instantly and permanently.
It is a profound, exhausting medical journey to map.
It really is. When you take a step back and synthesize all this data, you are forced to reflect on the sheer resilience of the human body, but also the terrifying destructive complexity of its potential for malfunction.
Very well said.
We've spent this deep dive dissecting the exact same cellular material endometrium, just glands and stroma.
Right.
But depending entirely on its trajectory, whether it escapes outward into the vast open space of the pelvic cavity or burrows deeply inward into the dense confined muscle of the uterus, it dictates two entirely different, uniquely devastating landscapes of chronic disease.
The contrast between the two is striking, yet they share the same fundamental biology. Endometriosis is the aggressive, disseminating disease of the young, nulliparous woman spreading across multiple organ systems.
Ah,
Adenomyosis is the relentless, burrowing disease of the older, multiparous woman trapped within a single organ. Yet both are relentlessly driven by the exact same inescapable rhythm of estrogen, and both perfectly exploit a localized failure of the body's immune response to survive and thrive.
which leaves me with a final provocative thought for you to ponder as we wrap up.
What's that?
We have spent this entire deep dive analyzing ways to fight this tissue. We talked about starving it with pseudomenopause, tricking it with pseudopregnancy, literally cutting the pain nerves to the brain, and surgically excising entire organs.
Right.
But the underlying data repeatedly points to a fundamental systemic failure. The macrophages failed to clear the retrograde cells, and the peritoneal fluid degraded into a hyperinflammatory pro-growth soup that nurtured the invader.
Yes.
So the peritoneal environment and your own immune macrophages are what ultimately grant these rogue cells permission to survive. Could the future of curing endometriosis lie entirely outside of manipulating reproductive hormones?
That's a huge question.
Could the ultimate cure be found not in shutting down a woman's ovaries, but in fundamentally reprogramming her immune system to finally recognize and destroy the invader?
It's certainly a paradigm shift.
Something to ponder. Until next time.